All of you are welcome in today's session. So today's session is all about the adrenal gland disorders. In adrenal gland disorders, so first we'll start with the basic anatomy and physiology of adrenal gland. The adrenal gland is mainly located above the kidneys. By the name itself is telling above the renal, means ADRENL, above the renal. That means above the kidneys. And the important function of adrenal gland is that it synthesizes some hormones. So there are two parts of adrenal gland: the outer cortex and inner medulla. Outer cortex is having three zones: zona glomerulosa, fasciculata, and reticularis. In zona glomerulosa, mineralocorticoids are synthesized. In fasciculata, glucocorticoids, and in reticularis, androgens are synthesized. The most important mineralocorticoid in human body is aldosterone, and the most important glucocorticoid in human body is cortisol. You should remember these two very well, okay? And in androgens, dihydroepiandrosterone is synthesized, which is a precursor of progesterone. Testosterone is responsible for development of pubic hair, axillary hair, and is responsible for libido also. So what is the main function of cortisol? So cortisol is a stress hormone. So like in every stress condition, the cortisol is released in a fight and flight response. So cortisol is an anti-inflammatory. Also, it regulates the blood pressure. It is responsible for insulin resistance, protein catabolism, and immune response. So whenever the cortisol levels are high, the patient will be prone to develop diabetes because of insulin resistance. What is the function of aldosterone? Aldosterone is responsible for sodium and water retention, so it will cause hypertension. And in adrenal medulla, the catecholamines are synthesized, that are epinephrine and norepinephrine. In case there is a tumor in adrenal medulla, so the name of the tumor is Pheochromocytoma, the epinephrine and norepinephrine will be increased. So the patient will have symptoms such as flushing of face and increased heart rate, increased blood pressure, headache, palpitations, and patient will complain mainly of a impending doom. Okay, the patient will complain mainly of like impending doom. He will have faintness and increased blood pressure and all. Okay, so these are the basic things you should remember in adrenal gland. And now we'll proceed to the first disease, that is primary hyperaldosteronism, which is also known as Conn syndrome. So what happens in primary hyperaldosteronism? The name itself is telling primary hyperaldosteronism, means there is no secondary cause of hyperaldosteronism. It is primarily due to adrenal gland disorders. So the causes are adrenal hyperplasia, the most common, adrenal adenoma, and adrenal carcinoma. So what happens when the adrenal hyperplasia occurs? So there is increased number of cells. So aldosterone synthesis will be increased, and this aldosterone will cause what? Sodium retention, and along with sodium retention, the potassium and hydrogen ions are excreted. So what is the condition the patient will have? Due to sodium retention, water will also be reabsorbed. Okay, so the patient will have hypertension, and potassium and hydrogen ions are excreted. So hydrogen ion excretion will cause metabolic alkalosis. So these are the clinical features of primary hyperaldosteronism. Like the patient will have hypertension, reduced potassium. So the normal value you should be aware, that is 3.5 to 5.5 millimoles. So the patient will have less than 3.5 millimoles potassium levels. So it will cause muscle weakness, and due to hydrogen ion excretion, the alkalosis will occur. So what are the investigations to confirm whether the patient is having primary hyperaldosteronism or not? See, first we have to rule out whether this hypertension the patient is having is due to primary hyperaldosteronism or due to secondary hyperaldosteronism. The most important cause of secondary hyperaldosteronism is renal artery stenosis. Okay, what renal artery stenosis? So in renal artery stenosis, there is secondary hyperaldosteronism, but the renin level is also increased in renal artery stenosis. But in case of primary hyperaldosteronism, there is no increase in the renin, so there is isolated increased serum aldosterone. So the investigation is renin aldosterone ratio, in which the serum aldosterone level will be increased and there will be low renin. Okay, for localization of the tumor, you can do HRCT or MRI. So what will be the management? First of all, the patient is having increased sodium retention, so we have to restrict the sodium intake. Okay, and there is increased aldosterone, so we have to give aldosterone antagonist, that is spironolactone. Spironolactone is given for many years for adrenal hyperplasia. And in case you are planning for surgery, then the treatment will be adrenalectomy, the surgery for adrenal adenoma. And there is another cause of hyperaldosteronism, that is glucocorticoid remediable hyperaldosteronism, and the treatment for that is dexamethasone. I will tell you about it as we move forward. Okay, so what happens in primary hyperaldosteronism? There is hypokalemia and hypertension. So there will be some differential diagnosis also for these conditions, like Conn syndrome is one of them, Cushing syndrome is one of them, Liddle syndrome is one of them, which is also known as pseudo hyperaldosteronism, 11 beta hydroxylase deficiency, and licorice excess. Okay, so now we have to diagnose. The patient is coming to us with the complaints of hypertension, and we do some electrolyte investigation and we say hypokalemia. So we should keep these 5 differential diagnoses in our mind, and to rule out these, so we have to see some specific findings of these conditions. Okay, but please remember, 21 hydroxylase deficiency does not cause hypertension. It is associated with precocious puberty in boys. and 11 beta hydroxylase deficiency is responsible for causing hypokalemia with hypertension. 21 hydroxylase deficiency does not cause hypertension, it causes precocious puberty in boys. Okay, so now you know how to diagnose Conn syndrome. You know we will do the investigation renin aldosterone ratio. In that we'll see aldosterone levels will be increased and renin will be low. Second thing, we should be aware about the Liddle syndrome. So what happens in Liddle syndrome is there is an inherited mutation of the collecting tubule sodium channel, so there will be increased sodium reabsorption. So there will be increased sodium reabsorption, but there will be no increase in the aldosterone. Okay, there will be increased sodium reabsorption, but there will be no increase in the aldosterone. Okay, so this isolated increased sodium reabsorption we can differentiate because there is decreased aldosterone, but in Conn syndrome there is also increased aldosterone. Okay, so in licorice excess, it is like a herbal remedy. The usually patients used to take in ancient times for gastric issues, or it is also used in candies and lozenges for cough. Now you can differentiate these two conditions with Conn syndromes. If the patient is coming with hypokalemia, with hypertension, so if the Liddle syndrome is a cause, then there will be a family history positive because it is an inherited condition. And in licorice, you can ask about the history, whether the patient has taken any herbal product or candy or lozenges. Okay, so we can easily differentiate Liddle syndrome, licorice excess, and Conn syndrome. Okay, in Liddle syndrome there is decreased renin, decreased aldosterone. All of the features are like that of primary hyperaldosteronism. Okay, so the main complaint is of increased blood pressure. And in Conn syndrome, we see that there is decreased renin, increased aldosterone, hypertension, hypokalemia, metabolic alkalosis. In renal artery stenosis, I told you about the secondary hyperaldosteronism before. In renal artery stenosis, the renin level will be increased. So we can easily differentiate renal artery stenosis with these syndromes. Okay, Conn syndrome, Liddle syndrome, or licorice excess. Okay, by checking the renin aldosterone ratio. So you know the basic mechanism. When there is reduced renal perfusion, there is sympathetic stimulation. The JG cells are stimulated, which secretes renin. Renin is responsible for conversion of angiotensin to angiotensin 1. Then angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, and which stimulates the aldosterone production. Okay, this aldosterone is responsible for causing hypertension. Okay, now I told you about glucocorticoid remediable hyperaldosteronism before. Here I told you about glucocorticoid remediable hyperaldosteronism. In case of management, we give dexamethasone. So what happens in glucocorticoid remediable hyperaldosteronism is that there is reduced cortisol. Okay, there is no cortisol production in our body, so there is no negative feedback on anterior pituitary. So there is no negative feedback on anterior pituitary, so will be increased ACTH secretion. Okay, so this ACTH will stimulate adrenal gland, mainly zona glomerulosa, and there will be increased aldosterone.